Thanks so much for the introduction. Thanks again for joining today and for this opportunity to speak a little bit about advances in diabetes technology. Our objective is really for today is really to review the current diabetes technology that's out on the market, and this will include things like insulin pumps and continuous glucose monitoring systems and how they're used in outpatient diabetes management. That being said, sort of a disclaimer that the technology is advancing quickly and changes frequently. So if anybody has any updates, I'm also happy to hear about those. Taking a look back before we start on this journey through technology, we've known about diabetes for a really long time. And I think the term was first used in the 1700s with a delay sort of in treatment until 1920s when we discovered insulin. If you look down here, I don't know if you can see on the screen here where we point, it wasn't until 1921 when we discovered insulin for treatment, and then not until 1957 when metformin was first put on the market. When we go forward in time, we see that it was until the 1970s when home blood glucose monitors were introduced. And then later in the 1990s, we see the landmark diabetes trials that looked at glycemic control and outcomes for patients with diabetes. Further on out, we see things like continuous glucose monitors, which are relatively new, first developed in the late 1990s, and then all of these new medications for the treatment of type 2 diabetes, which we will talk about at a later time in the webinar. So with all of this technology, what is the ultimate goal? Well, one, we want to make sure that patients have excellent glycemic control to prevent complications of diabetes. And we do this by trying to approximate physiologic insulin secretion. So today we'll talk mostly about technology that focuses on insulin administration and glucose monitoring, with two of the most common methods for administering insulin being multiple daily injections, using basal insulin, as well as a rapid-acting insulin. And we'll also talk about continuous subcutaneous insulin infusion, also known as insulin pump therapy. To start, we'll look back at advances with insulin creation. So again, insulin was first used clinically in 1922, with NPH insulin, one of our older insulins, synthesized in the 1950s. And then later on, much later on, we get the rapid-acting insulin analogs in the 1990s, and then the long-acting basal analogs later after that. You'll see here that there's also an inhaled insulin that's mentioned, and we will touch on that later. So the creation of all of these insulins themselves was part of the technology of diabetes management. We'll see here the basal insulin action profiles that provide continuous insulin coverage throughout the day, not related to food intake. And the goal here is to provide a non-peaking action for almost 24 hours. Some of the newer insulins, including Glargine U300 and insulin degludec, really have a very long half-life and provide steady insulin coverage for over 24 hours. So that's desirable for basal insulin coverage. But what about when a patient eats and we have a huge glucose excursion? That's when we use the prandial insulin or rapid-acting insulin to cover that food intake. We see that some of the most common ones, like Aspart and Lispro, are very quick in onset, within about 15 to 30 minutes. Not quite as fast as someone's natural endogenous insulin, but getting pretty close. So the creation of these types of insulin has really helped manage glycemic control for patients in a much better fashion than we used to be able to. Some of the other older insulins had a slow onset and would peak at later times of the day. Mentioned we would talk about inhaled insulin. So the inhaled insulin that has come on the market is Afrezza. It's used as rapid-acting insulin only. There's no basal action for Afrezza, but it comes in little blister packets that a patient inhales prior to their meal, and they're dosed at either 4, 8, and 12 units. And you can combine them or add them up in any way you'd like, but there's a little cartridge and the patient inhales them prior to the meal. Some considerations for this are mostly related to a patient's pulmonary status and some potential pulmonary complications and monitoring. But this is definitely an option for some patients who are maybe averse to 3 injections per day. So I think we know that although the insulin is a great creation, patients need to use it, and diabetes is a time-intensive disease that requires a lot of effort, and adherence can really impact glycemic control. So there are many devices out there, we'll talk about 2 today, that help patients try to maximize their adherence and remember what they're doing during the day. The InPen is a little titanium pen here with a refillable insulin cartridge that helps people track how much insulin they've taken and what their glucose values are. It remembers the insulin doses that were administered, and it also tracks the units using the pen. Pen will automatically put those in the software, and the Bluetooth connection can send it to the phone and other glucometers. It also helps people calculate insulin doses, so things like dosing insulin based on carbohydrates that someone is eating is definitely a possibility using the InPen. It also will keep track of how much insulin is on board. So based on how long the insulin is thought to last, if somebody administers a dose early for a meal and then tries to correct later on with an additional dose, it will take into account that they still have some insulin hanging around. The settings are actually determined by the provider, so this needs to be used in conjunction with a healthcare provider who is managing insulin and diabetes care. There are reminders and data sharing for people who need a little bit of assistance with that, trying to keep on track or maybe very busy, and they can also have family members involved and try to help them with that as well. The Insulia app is really more for patients with type 2 diabetes who are just on basal insulin. And it really is sort of an agreement and work with a healthcare provider to titrate basal insulin doses and minimize hypoglycemia. There's an interface with the patient's healthcare provider, and they provide an algorithm to titrate basal insulin doses based on what the fasting blood sugars are throughout the week. So now that we've talked about multiple daily injections and that kind of technology, we'll move on to insulin pump therapy. We'll go back to another timeline that shows how insulin pumps have changed since the early 1960s when the first one was created. You'll see it looks like a backpack and seems very impractical for daily use. By the late 1970s and 1980s, they had become a little bit smaller, but still a little bit burdensome for everyday use, which is in contrast to what we see now with many insulin pumps on the market that are very small, discreet, and easier for patients to use and interface with. This is a picture of another pump that we'll talk about later. So what is insulin pump therapy? You'll hear some people refer to it as continuous subcutaneous insulin infusion, but really it's allowing for continuous subcutaneous administration of rapid-acting insulin analogs. So we only use either Aspart or Lispro typically in the pumps, and it's administered via a little plastic catheter in the subcutaneous tissue that gets changed every 2 to 3 days by the patient. The administration is based on insulin pump settings, which include setting basal rates for basal insulin coverage throughout the day, bolus calculators and bolus dosing that cover a patient's mealtime food intake, and also corrective dosing and target glucose values for corrective insulin dosing. So what does it look like? Well, insulin pump therapy has come a long way. These are 4 of the most common products that we see here. MEDTRONIC, this is an old MEDTRONIC pump, an older version. you'll see here that a lot of patients still have today. This is one of the newer MEDTRONIC pumps that's come out. The Omnipod is more of a patch pump, which we'll talk about in just a little bit, with a pump controller here. The Animas pump, patients are still in clinic with this today, but Animas is no longer on the market. And then also the Tandem T-Slim, which is the only touchscreen pump here on the market so far. So these are all of the controllers, so the actual insulin pump, if you will, where patients make decisions and input information to control their insulin levels that are being administered. So how does that do that? So there's three key parts aside from the controller of the pump. We'll start down here with the reservoir. So this is where the insulin is stored. It's usually between 200 and 300 units. And there's many ways to fill these reservoirs, but they sit in the pump and they hold the insulin that will be administered for the next 3 days. Then there's also the infusion site and the cannula. So this is a component of every pump. There's a small flexible plastic cannula that gets inserted into the subcutaneous tissue by a little retractable needle that is very painless actually. It's connected to the reservoir by tubing, which can be different lengths depending on patient preference. The only pump that does not require tubing is actually the Omnipod, which is the little patch pump, but it does still have a cannula and then a reservoir. So we have this insulin pump therapy, so what is the goal? The goal is to even better approximate physiologic insulin secretion and provide patients with flexibility based on their lifestyle. So we know that people often require a little bit of different basal insulin during the day. So sometimes when people are more active, they may not need as much basal insulin, sometimes they need more. They also may not eat at consistent times, and they may want to correct or eat multiple meals or exercise. So they have the option to adjust their insulin because it's being continuously infused to accommodate for all of these activities. So who might be a candidate for insulin pump therapy? I think this is a complex question. So a lot of people used to think that it was mostly patients with type 1 diabetes, but both patients with type 1 and type 2 diabetes can be candidates for pump therapy. If we talk about patients with type 1 diabetes, there are a couple of criteria that the American Association of Clinical Endocrinologists in 2014 said might benefit most. So those who are not reaching their glycemic targets, so people with high A1Cs who have very labile diabetes characterized by extreme glycemic variability, so multiple highs, multiple lows, and also those with recurrent DKA. Those who have frequent hypoglycemia may be able to adjust things to help prevent that. And also an indication would be for those people who really need a little bit more flexibility and have challenges with schedule and managing their diabetes. In type 2 diabetes, we'll talk about some of the recommendations, but a lot of times this also depends on insurance. So qualifying for pumps with type 2 diabetes is a little bit more complicated, especially using Medicare coverage. In 2016, the Endocrine Society put forward some guidelines regarding insulin pump therapy, sort of similar. Those who have type 1 diabetes who aren't at goal in terms of their A1C targets, who are on multiple daily injections, and those, again, with hypoglycemia or extreme glycemic variability, even if their A1C is at target. And also, again, those who wanted more lifestyle flexibility or felt that pump therapy might improve their quality of life. Those with type 2 diabetes who have poor glycemic control, again, might be candidates. And this would be despite intensive insulin therapy, oral agents, and other injectable therapies, as well as lifestyle modifications. I think this sentence sort of sums up things as well. So with this technology, it requires a lot of effort to be used properly. And so both the patient and the caregiver really need to be willing and able to use the device correctly and appropriately, and also have a lot of follow-up. There are some other factors to consider when thinking about using the insulin pump for a patient. You have to sort of see what their baseline glycemic control is. Do we expect big improvements with the pump? So people who have A1Cs that are significantly above goal, maybe 10 or 11, may see big improvements, but those who don't have significantly high A1Cs may see smaller improvements. They must be able to really come to their follow-up appointments. Using insulin pumps is complex and requires frequent dose adjustments to be used appropriately and safely, and providers need to also be able to accommodate that. The patient also needs to recognize that there's limitations of pump therapy. I think with a lot of the publicity that talks about artificial pancreas, which we can go over later, there's this misconception by many patients that an insulin pump is going to automatically take care of their glycemic control and moderate things. That is not the case, so the patient needs to be very involved with this therapy. We also need to make sure that we've assessed for any kind of psychological disease that is likely to impact patients' adherence or ability to use the technology safely. And again, just confirming that the patient's willing to follow up, especially in the time when you're initiating the pump therapy. I think this is, again, a summary that's in the guidelines for somebody who may not be a good candidate. And I think one of the most important ones is to manage unrealistic expectations of pump therapy. Again, this is the belief that the patient won't have to put in any effort in order to achieve good glycemic control, and that the pump will sort of automatically do that for them. So how does insulin pump therapy impact glycemic control? If we start somebody on an insulin pump, what do we expect? So there's some data from early studies in patients with type 1 diabetes that when put together showed improvement in A1C levels, lower rates of hypoglycemia, less glycemic variability, improvement in some lifestyle and flexibility and quality of life for certain patients. But there was also this concern that the use of only a short-acting insulin in a pump might increase the risk of DKA if their pump were to malfunction. So although we always caution patients about that risk of going into DKA if the pump were to malfunction, there were certain studies, so one using the Type 1 Diabetes Exchange, which is a data registry of over 25,000 patients with Type 1 diabetes in the US, who took a look and they looked at insulin delivery methods, so pump versus multiple daily injections, and actually found that there wasn't any significant difference in DKA occurrence between those using pumps or injections. A study in Germany undertook the same goal to see if DKA was more frequent in those on pumps. They again actually found that there were lower rates of DKA. Lower rates of DKA in those on pump therapy. So when used appropriately, it appears that that risk of DKA is not increased compared to multiple daily injections. When we look at patients on pump therapy who have type 2 diabetes, there were many comparisons. Actually, you can see that pump therapy did improve their glycemic control significantly. So if we look at baseline A1C, you still see an improvement with multiple daily injections from prior. And then also that pump therapy did improve the A1C in many patients. It was not always superior to multiple daily injections, but many people did see an improvement in their A1Cs. When we, again, pool all of this data together in a meta-analysis, they did see improved glycemic control in type 2, reduction in insulin requirements. There was no change in weight, but we did see the most improvement in those who started off with higher A1Cs and poor glycemic control with high insulin requirements compared to those who had already better glycemic control in the beginning. There are other practical considerations to insulin pump therapy. A lot of times we get this right out of the door. The cost is often prohibitive for many patients. So the initial setup cost to purchase an insulin pump definitely requires insurance coverage. And you have to think about the supplies that the patient needs to purchase that are changed every 3 days, which we also know is labor intensive. And some patients have very bad side effects in terms of the adhesive that's used to secure the infusion sites for the pump. We know that the devices can malfunction and that sometimes the infusion sites can become blocked. And again, that was the concern, that there may be higher risk for DKA. But also that, not every patient knows how to use an insulin pump properly, and that's continued education, but that if we feel that there's improper use, that needs to be addressed. Showering and swimming can sometimes be difficult. The patients do have to disconnect from certain pumps when they shower or they swim, which can increase that risk of DKA and running out of insulin if they stay disconnected for a prolonged amount of time. And there's some personal preference considerations as well. It's good to encourage people to really know what insulin pump therapy is before they start it and to do some background information checking. Some patients think that, pump would be great and they try it for quality of life and actually find that it's more invasive than they thought and may not prefer it. So that does happen. So after all of this, patient decides to start on insulin pump therapy. I wanted to talk a little bit about how we determine setting up those initial settings and what are the settings that we need to determine. First and foremost, we need to know how much insulin a patient needs every day, so the total daily insulin dose. This is really an estimate. If somebody's not on insulin currently and they're just being started on a pump right off the bat, then we can use a weight-based method for determining the total daily dose of insulin, which is their weight in kilograms, usually times a factor of 0.5. This factor varies based on how insulin sensitive or insulin resistant you think someone may be. If someone's already on insulin, multiple daily injections, then typically we'll reduce their total daily insulin dose, which is basal plus mealtime insulin, all added together. We'll reduce that to about 75 or 80% of the dose. And this is really to avoid hypoglycemia. So sometimes, when patients are on multiple daily injections, they may miss certain injections. They have a habit of missing one during the day. With the pump, and if the pump is on, they're going to be getting all of that insulin. So we tend to underestimate a little bit to avoid hypoglycemia. So once we determine how much insulin they need in a day, how do we split that up between their long-acting basal needs and their prandial needs? The next thing we do is we determine the basal rate. So we take the total daily dose and split it in half. So 50% of the total daily dose becomes basal insulin. So once you have that amount, you divide it by 24 hours, 24 to get an hourly basal rate. And this is the insulin that's administered, the total insulin that's administered every hour by the pump. The pump is able to change how fast or how slow it administers the basal. So you can change how much somebody gets for basal coverage during the day versus how much they get at night, especially for those who may be prone to overnight lows. When we think of this, we say, how many basal rates does a patient need? So maybe they require a little bit more insulin during the day or less overnight, or vice versa, actually. So pumps can be programmed to have many number of basals certain times of day. When they looked at patients who were using pumps, they saw that pretty much most people have between, let's say, about 3 or 4 basal rates. Once we get beyond that, I think it's difficult to tell. It seems like there might be something else going on if a patient is really having that much variability in their basal requirements. Typically, it's related more to food or activity or something like that. But most people use about 2 or 3 settings for their basal rates. Typically, the most typical pattern is have a daytime insulin rate and a nighttime insulin rate. So for more settings, we also need to know how much insulin a patient needs to cover their food. This is determined by the insulin to carb ratio. So patients must learn how to carb count before they can use an insulin pump. The number of grams of carbohydrate that the patient is eating is how the pump determines how much insulin to bolus for their meal. We make this calculation by taking the number 450 and dividing it by the total daily dose that we calculated earlier. This gives us what we call the insulin to carb ratio. So if we get a number of 10, we set that as 1 to 10, which means 1 unit of insulin is going to cover 10 grams of carb eaten. We also need a sensitivity or a correction factor to come in. So if the patient starts off with a high blood sugar, we want to add a little bit of extra insulin to try to bring it down. This is determined by taking the number 1700 and dividing it by the total daily dose. You get a number such as 50, which means you expect 1 unit of insulin to lower the blood sugar by 50 milligrams per deciliter. With the sensitivity and correction factor, we also have to set a target glucose, which is different for certain people depending on how aggressive we want to be in terms of their glycemic control. You'll see that some pumps, particularly the MEDTRONIC pumps, have a target glucose range. It'll say something like 90 to 150, which means at 150, the pump is going to add the correction factor insulin to correct anything that's above 150. If a patient has a blood sugar lower target of 90, that means if their pre-meal blood sugar is less than that target, the pump will take away the same amount from their bolus dose. Other pumps just have a single target glucose value, like the Omnipod and the t:slim, but they also have reverse correction, again, which subtracts from their bolus dose if they're eating for low blood sugars. These are just some pictures what this looks like. So there's a target that says correct above, and they set it 140 there. And then again, the target blood sugar here on the t:slim of 120. In addition to making all of these calculations, the pump helps patients avoid hypoglycemia by determining how much insulin is still active that they've injected. You'll see this here by active insulin. So it will adjust for how much insulin they think is still hanging around from the last bolus or correction dose they made. The setting on the pump that we use to help determine that is called the duration of insulin action. So this is really based on how long we think the rapid-acting insulin analog is staying in the body. It can be set on the current pumps anywhere between 2 and 8 hours. So we think that the insulin may last 2 up to 8 hours. The typical duration of insulin action that we set is generally 4 hours, maybe 5 in the majority of these patients. So that's based on the duration of action of the insulin itself. But an inaccurate duration of insulin action can significantly impact control. If we set a very short duration of action, the pump will let the patient bolus again and say, you don't have any active insulin, when in fact it may be hanging around. So that can lead to hypoglycemia. So here on this graph, we see that if we want to be a little bit more aggressive, we set a shorter duration of action, but also it might be a little more safe to err on the side of having it last about 6 hours. And again, this is all done to avoid insulin stacking for patients. So bolusing too frequently and then having subsequent hypoglycemia. We also need to be careful in patients who have impaired renal function. So we know that there are disturbances of glucose metabolism that are associated with renal disease. These include both decreased insulin clearance and hypoglycemia, and also increased insulin resistance and resulting hyperglycemia. And we have to keep in mind that patients with renal disease may not clear insulin as quickly. With the insulin pumps, in terms of flexibility and patients having a little more control, tight control over situations, we think about certain functions of each pump that allow them to have this control. So there's something called a square or dual wave bolus that really delivers a bolus evenly over a period of time. And they can decide how long they want to have that bolus last. There's an extended bolus, again, with a percentage of that bolus insulin dose given right away, and then the remaining amount is given over a specified duration of time. So this is helpful for large or prolonged meals, or also for patients who may have gastroparesis, where the food is absorbed later. It can also help sometimes with high-fat meals, where you get a glycemic excursion from the fat later on. There are also temporary basal rates that can be set. So this means that the patient doesn't necessarily have to change the settings of their pump, but they can decrease how much basal insulin they're getting or increase how much basal insulin they're getting for a short amount of time. This is often done in the setting of exercise, where patients will decrease the amount of basal insulin they're getting to avoid hypoglycemia associated with increased activity. And sometimes illness will also require a change in basal rates. Sometimes patients will require more insulin during illness. I wanted to talk about one of the items on the market called the Vigo. This is sort of a hybrid between multiple daily injections and an insulin pump. So this is something called a patch pump, and it can actually, it administers a fixed dose of basal insulin during the day. So maybe 20 units, 30 units, or 40 units. And then it also gives a metered prandial dose of insulin just by the patient clicking on the pump. So it's using short-acting insulin, but in a pump fashion to sort of improve adherence for people who may not be able to carry insulin pens and inject 3 or 4 times a day. This pump does not have the settings that we just went over. So this is really similar to multiple daily injections, but administered in a pump form. Now we'd like to move on to continuous glucose monitoring. So this is another technology that's often used with insulin pump therapy and on its own that helps patients manage their diabetes. So continuous glucose monitoring is also done subcutaneously, and it's via a little sensor that's inserted, again, into the subcutaneous tissue, but measures the glucose in the interstitial fluid. This is compared to the capillary glucose that we get from point-of-care blood glucose monitoring. So how do we determine how accurate that measurement of glucose in the interstitial fluid is compared to, say, point-of-care glucose that a patient would normally check on their meter? This is done by looking at something called the MARD, or the mean absolute relative difference. It's the accepted measurement of CGM accuracy. It's reported as an overall percentage difference, and it can be influenced by different things. So the reference measurements can either be capillary blood glucose or something else, potentially venous blood glucose, glycemic variability, and there's also a time delay between, again, like capillary blood glucose and the interstitial fluid. But there's a certain threshold of that difference that must be met in order to make a treatment decision for a blood glucose. So that means there has to be less than 10% of that difference in order to be confident enough in this continuous glucose monitor's value to decide what to do based on that blood sugar. So if a patient says, oh, I'm 85, they need to be confident enough to say, I really think that that's 85 on my CGM, and now I'm going to eat my meal, but I'm going to give less insulin. Things that can compromise the accuracy of a CGM, these are sort of being addressed by many of the companies, but it used to be that Tylenol would interfere with some devices, but a lot of these things are no longer true. There are continuous glucose monitoring systems that don't communicate with pumps, which we'll talk about later, but they're called standalone CGMs. So this is really just for a patient to wear a continuous glucose monitor and understand what's going on with their glucose all day. So when they wear it, they have a little sensor that's attached all the time, and they get glucose readings about every 5 minutes. This is something called the Freestyle Libre, which is a flash meter. So the patient will put the round sensor on the back of their arm and use the device here. They'll flash it over that and they'll get a reading that tells them their blood glucose level and then a trend, whether it's headed up or down. And this will help them monitor that during the day. The Freestyle Libre does not require calibration. That means that the sensor reads the interstitial glucose, but does not need to know what a point of care glucose is to be calibrated. It's done on its own. This meter does not alert the patient if there's a low blood sugar or if it's heading towards a low blood sugar or a high blood sugar. So this one must be flashed over the sensor. You have to physically put the little reader over the sensor on the back of the arm in order to get the information. It does not continuously alert a patient. Contrasting to that, there are other systems, including the new MEDTRONIC Guardian Connect, which you see the sensor here. It continuously monitors the blood sugar and interfaces with a program on the phone, which does set off alarms if the patient is headed towards a low blood sugar, high blood sugar, or is changing, the rate of their glucose is changing too quickly. Another common system is the Dexcom. So their latest model is the Dexcom G6. Again, there's no need to calibrate the sensor to make sure that it's in line with a finger stick blood glucose by calibrating it. It does that on its own and has been shown to be accurate by MARD. So they insert the sensor, it reads their glucose and sends a signal either to a phone or a receiver, and does alert a patient, again, if there's a low, a high blood sugar or a fast rate of change in their blood sugar. So these are really helpful for patients who may not have awareness of their low blood sugars or who have significant changes and need to follow things very closely. There's also a new device made by Eversense, which is an implantable CGM. It's a very small little glucose sensor that gets inserted, again, just under the skin into the subcutaneous tissue, and then has a little transmitter that attaches on the outside and transmits to a phone to alert patient to their glucose values. The Eversense is a little bit different in that it's changed, so this little sensor is removed every 90 days and reinserted by a healthcare provider. And the transmitter that attaches is also able to vibrate on the patient if there's an alert from the system. So say they were having a low blood sugar and it was at night, they can set it to actually vibrate on their arm. So how effective is continuous glucose monitoring at improving outcomes? There were a lot of early studies from the JDRF cooperative that are summarized here. So they actually showed grouped by age category. So they looked at children ages 8 to 14, adolescents between the ages of 15 and 24, and then adults who are 25 years or older. They were either using insulin pumps or multiple injections, and they compared continuous glucose monitor use versus the point of care finger stick glucose at home. They didn't see much of a difference in children or adolescents between the control group, who was using their finger stick glucose, versus the continuous glucose monitor group, but they did see a significant improvement in those over the age of 25. And this was an A1C. So more adults reached a target A1C of less than 7 after 6 months. They extended this study in 2010 and took the control group, who was using their home finger stick glucoses, and put them on CGMs to sort of mimic a more real-world use, so not a randomized controlled trial that was being done. They took those 214 patients, and they actually showed an improved time in their target blood sugar range and fewer hypoglycemic events, again, in adults age over 25. They didn't see much of a significant change in adolescents or children, but hypoglycemia, again, was improved in some of those patients. Again, sort of going back to adherence, we know that if you have a continuous glucose monitor, it's really only helpful if you look at it. And that's what this study by Bailey showed, that the more you look at the CGM, the better your reduction in A1C. So you have a lower A1C. So they looked at people who looked frequently and those who looked infrequently and compared them, and showed that those who looked the most frequently had larger improvements in their A1C. So thinking about those two items with the pump and the CGM, how can they be integrated? So this has been done, and you might hear of something called sensor-augmented pump therapy, which actually means that the glucose monitor, the continuous glucose monitor, is worn, but that little tracing and the data from it with the blood sugar and the trend is actually displayed on the pump's controller screen. This happens for Medtronic, the Tandem T-Slim, and again with the Animas pump. It's also meant to reference the use of a separate CGM system and insulin pump that are used simultaneously. So the CGM transmits maybe to the phone or a receiver, and the insulin pump stands on its own. And this is what happens with Omnipod currently. So patients can use both devices at the same time, but it doesn't necessarily display on the screen of the pump. That's different from insulin pumps and continuous glucose monitors that communicate. These are functions that we think of where the input of the blood sugar from the continuous glucose monitor actually influences what the pump is infusing in terms of insulin to the patient. One of the first functions was in the Medtronic MiniMed, started on the 530G, which is called threshold suspend. So the patient sets a glucose value, a target, say maybe 60, at which point if the continuous glucose monitor says we've hit a blood sugar of 60, the pump will stop infusion of all insulin in order to avoid subsequent hypoglycemia. There's also a predictive low glucose suspend. So because we see both glucose values from the CGM, but also trend information, insulin on the Medtronic 670G and the T-Slim X2 pump can be suspended if there is a trend indicating that the patient is going to hit their threshold glucose value within a certain time. So it will suspend it before the low blood sugar happens. So all of these advances are meant to really improve glycemic control, but mainly avoid hypoglycemia here. The next step would be, we have data on the threshold suspend that showed patients that were using this technology in a 3-month study showed significant decreases in mostly nocturnal, but overall hypoglycemia. So overnight, they were able to avoid lows, and it did not result in a rise in their A1C, so not at the expense of excellent glycemic control. See here that the threshold suspend group during their study phase had much less hypoglycemia overnight. And their A1Cs remained about the same. So the next step in this sort of road towards an artificial pancreas is something we call a hybrid closed loop system. And currently this exists with the Medtronic 670G. There is an auto mode in this pump and the associated continuous glucose monitor sensor here. So this communication system. that has a preset glucose target of 120. It always wants the blood sugar to be targeted towards 120. Temporarily, you can set it to 150, potentially in the setting of exercise. But it adjusts the basal rate of insulin every 5 minutes in order to try to reach that target of 120. It still requires input regarding meals and carbs, so it cannot keep up with that. So a patient must still enter their carbs in bolus for meals, but it will adjust the basal rates of insulin to try to target a glucose of 120 at all times. It still does have predictive low glucose suspend. So again, if the blood sugar is reaching a target low threshold, it will suspend all insulin infusion to avoid a low. And it will do it up to 30 minutes before. In addition to these automatic functions of this pump, you can still use it in something called a manual mode, which means it functions like all of the other pumps that we had talked about. You can, and this happens too, it will revert to a manual mode if it's not receiving input from the continuous glucose monitor. So if there's a delay or something happens and there's no information for it to automatically adjust the basal rate, it will revert to preset settings that the provider has entered so the patient can use it like one of the other insulin pumps. So with this auto mode technology, they looked at safety and efficacy of this MEDTRONIC 670G in adolescents and adults with type 1 diabetes. So they used the pump in manual mode where they had set basal rates and set carb ratios and used it for 2 weeks as it was set. Then they converted to auto mode for 3 months, again targeting that fixed blood sugar of 120 or temporary 150. And they showed improvement both in time and target blood sugar range, but also hypoglycemia and A1C, and particularly overnight hypoglycemia for many patients. Actually, you can see here, these are the baseline characteristics of the study population. In the adolescents and adults, fairly similar, except for duration of diabetes. This is the sensor tracing where you see the glucose levels all day on average for the adolescents, so slightly higher than we see in the adults. But all fairly stable and targeting that 120 level. So in summary, diabetes management technology has really come a long way, especially in the past 10 to 20 years. Things are changing very rapidly. So using insulin pumps and CGM technology can really improve glycemic control and also reduce the frequency of hypoglycemia when it's used appropriately. And again, it's necessary to provide patient education both prior to use of the new technology and also address their expectations as to what it's going to provide them. And successful diabetes management with all of this technology always requires continued close follow-up and a multidisciplinary healthcare team. We can't do it alone. We all have to work together, and it's important that the patient have a really nice support system and follow up frequently. Thank you.